with us throughout the entire journey. I welcome you, Father. It's my great privilege to welcome our beloved principal, Professor Dr. Usha Marath, organizing chairperson of our webinar, who constantly inspires, nurtures, and helps us to build resilience to the emerging challenges. I welcome you, ma'am, in my humble words. I would like to welcome Professor Lisa Peter, Vice Principal, Lisie College of Nursing, who works tirelessly for the progress of our institution. I welcome you, ma'am. I'm extremely honored to welcome our most respected speakers of today's session. Dr. Achila Gaikwad, Associate Professor, Himalayan College of Nursing, Dehradun, who was kindly consented to be the speaker of today's webinar. On behalf of Lisie family, I extend a hearty welcome to you, ma'am. I'm also delighted to welcome Mrs. Ashley Jacob, Dementia Trainer, ARDSI. In spite of her busy schedule, she happily accepted our invitation. I welcome you, ma'am. It's made me immense pleasure in welcoming Dr. Bindu Jos, nurse practitioner, Terrace Health, Arizona, USA, for being here and to share her knowledge and vast experience. I welcome you, ma'am. I extend a hearty welcome to all respected members of Lisie College, heads of various departments, and all delegates to our webinar. Let us hope that this talk and discussion would benefit all of us. Let's work together to make this webinar a grand success. Thank you. Now I request our Honorable Director, Father Paul Karadan, to address the gathering.
Good morning to everybody, and I'm honored to give an inaugural address to the people who are attending the webinar today. I most welcome the whole group of people. I think there are almost 100 people already joined the webinar, and I am very happy that it will be a very useful webinar for to be compassionate to the people who are Alzheimer's. Today, as we celebrate the Alzheimer's Day, I am also worried and having a lot of concerns in the future. I happened to read article today by Dr. P.S. Baby Chakrabani in Malayalam Manorama, and he indicated within 10 years, probably the number of Alzheimer's patients will be 2 to 3 times greater than what we have today. So we are tackling a point which is very important for the mental health of people and the well-being of people. This is a day we are very responsible healthcare workers and those who are getting trained to healthcare probably should understand what is happening around the world, and we have to come up with solutions and preventive measures to take care of the situations in the country. And as you know, there are a lot of people who have problems recently with COVID, and the article suggests that even in the asymptomatic patients who have been who are affected by COVID may have the influence of the virus, especially in the brain, which is going to be affecting the mental functioning of the people. And this would enhance probably the number of Alzheimer's patients in the coming days. Slow and steady infections in the brain area would rather destroy the memory of the people and could increase the number of Alzheimer's patients. And as we know, these are the people who are uh, needing the mutual support from other people. They become so unable to do things by themselves, and not like other patients who are capable to do things by themselves. These people, especially who are with Alzheimer's, have to be helped by people around them. They become so unable, invalid. And this is the time we have to think about as a community to reduce the number of patients and help the people who are having the difficulties of Alzheimer's diseases. And one of the things that the newspaper, the article was suggesting, the people should be very careful about their health care, especially in their eating habit, their yoga practices, exercises, and sleep patterns. They should have a good sleeping pattern. And we have to try our best to avoid this kind of situation, whatever possible way, what we can, to avoid and reduce the number of patients. Probably early understanding of the symptoms and how we can take care of the people would give us better opportunity and empowerment in the healthcare sector to take care of the people who are affected by the Alzheimer's disease. And I congratulate the organizers, especially Usha Madam and other people who are with her, the team working together, and especially taking up a very important topic for discussion and consultation on this right day, which is one of the most important need of the time. And I congratulate them. And I also give my regards and best wishes to the guest speakers who are in their busy schedule have come down to be with us, the Lisie family. And I want to thank them. And I offer all the wishes for all the participants. They will be able to gain very important information about Alzheimer's from the speakers, by which they will be able to do their best in this health sector. Thank you, and God bless, and all the best wishes for all of you, the organizers and those who are in participants, and those who are the speakers. And I give my best wishes to all of you. Good morning.
Thank you, Father. Now I request our beloved principal, Professor Dr. Usha Marak, to deliver a keynote address and to give her valuable inputs to our webinar.
Understand more about dementia, talk about and to demystify the concepts which are there. Thank you, Divya. And today is the World Alzheimer's Day, and it is usually a day which is observed to understand the importance and to talk about dementia and to demystify dementia so that more care can be rendered towards the people who are in need of it. If we look into what is dementia, I think it's slide. Dementia is an umbrella for term which is comprises of several neurodegenerative diseases affecting the memory, the cognitive abilities like problem solving, judgment, language, and also behaviors which usually interfere with the day-to-day activities, and ultimately it also inhibits their social interactions. Alzheimer's is one of the most common form of dementia, which accounts to approximately 60 to 70% of those cases. If we look into the global picture of dementia, WHO reports that dementia affects approximately around 50 million people worldwide, and the number of people living with dementia is thought to double every 20 years. And it is estimated that it will become around 81.1 million in 2040. Almost 9.9 million people develop dementia each year, of which 63% is residing in low and middle income countries. In the Indian scenario, if we look into, we can see that 104 million elderly persons, that is people above the age of 60 years, is residing in India, of which 53 million are females and 51 million are male. And this elderly, among this elderly people, 73 million elderly are residing in the rural areas. According to the ADRD report, it is estimated that 5.3 million elderly have dementia in 2020, which equals to 1 in every 27 people above the age in India is having dementia. And this is expected to double by 2035. Thus, the need to address dementia is very grave because it is the second largest cause of disability for individuals aged 70 years and older. And according to the Global Burden of Disease study by WHO and World Bank, dementia contributes to around 4.1% of all disability adjusted life years. It is also the 7th leading cause of death. And according to a study by World Bank and WHO, total global societal cost of dementia was estimated to be around $818 billion, which is equivalent to 1.1% of the GDP. So it affects the societal, both financially as well as a lot of strain is there on the individual, on the family, and the society. Caregiver strain does stretch the family to a very considerable level. The utilization of healthcare facilities puts a strain on the healthcare system and also on the national income. The burden of dementia is going on increasing because we have seen that the rate at which dementia is going to occur is very high because of the increasing longevity of the persons and also because of the increased prevalence of the modifiable risk factors which is there in the community. Looking at the risk factors which is there associated with dementia and related dementia or neurodegenerative disorders, one of the most important risk factor which is attributed is age. But we must always know that age is not very much telling that as age advances, dementia is inevitable. No, it's not so. The 9 modifiable risk factor, which has been put forth by and modeled by Lancet Commission after detailed evidence-based, include the lesser educational level of the people, hypertension, hearing impairment, smoking or tobacco use, obesity, depression, physical inactivity, diabetes, and social contact, low social contact. Further, based on more evidences, 3 more risk factors were added on to this model, which includes excessive alcohol consumption, traumatic brain injury, and air pollution. So this accounts to around 40%. These modifiable risk factor contributes to 40% of chances of developing dementia. This is being emphasized because these are some of the theoretically conceived preventable and modifiable factors which can be taken care of in order to either decrease the onset or to prevent the damages which occur in the process of dementia. The challenges in fighting ADRD, the Alzheimer's disease and related dementias, include the first one, which has been put forth, and a very important one, is the lack of public knowledge and awareness of the disease. In India, dementia and related disorders are a hidden problem. And it has been seen that people with dementia, the community awareness is low, particularly in rural area. The picture is fairly better in the urban and certain selected states like Kerala and Tamil Nadu. But in other rural areas, the concept or the knowledge regarding dementia or related disorders is very less among the general public. The main problem which arises because of this is the problem in detecting and diagnosing the disease. Because in India, the societal culture is such that dementia is considered to be a normal aging process. It is thought that as people age, they tend to lose memory. And in this process, they seek health care at a very advanced stage. So by the time dementia is getting diagnosed, the condition might have advanced to a very high level. Also, the healthcare places least importance to dementia care, and the caregivers are usually unprepared. They are not educated about how to care for the people with such a disorder, which places undue stress and strain among the caregivers and also the inability to care adequately for them. Inadequate treatment. This is also a problem which is faced all through India. As we can see that the treatment gap which is there, that is the people who are actually diagnosed with the illness and the people who are getting treatment, it is estimated that the gap exceeds around 90%. The picture may be slightly different in Kerala, but in other parts of the country, and particularly in the rural area, it is very high. Insufficient funding, both from the health sector and as well as other sources, is very less. Research fundings are very less in this particular area, and is still an area which is to be explored. The cost of care of a person with dementia is also very high. According to a study which has been taken up by Rao and Bharat, it is estimated that the annual household cost of caring for a person with dementia in India, depending upon the severity of the disease, ranges from around 45,600 to 2,02,450 in urban areas. And in rural areas, it may range from 20,300 to 66,025 in rural area. The study has been done in 2015, and it is thus may be fairly greater during this particular time. The ill-equipped communities, particularly, we have seen that the persons with dementia in the rural area are getting sometimes abandoned. Community resources are not adequate in order to support them. So these are some of the challenges which is usually seen associated with dementia and related disorders. COVID, as such, we can see, had a very great impact on normal individual itself. So the impact which can take place on patients who are already more vulnerable because of their illness, because of their comorbidity which they have, and also because of their symptoms. So definitely this places a very great burden onto the patients who had to adjust with the new normal which is going to be. They are the people who could find it very difficult to adjust with the normal things and normal routines. And when the whole routine gets upset, they had a lot of trouble following the safety COVID protocols of safety procedures. And as we know, they are a vulnerable group in which if there is an infection of COVID, it will lead to unnecessary complications, and it may even lead to the mortality of the individuals. Interruption of continued care, the regular care which was being rendered to them in the community got interrupted. They had to get used to those things, and it was a very challenging time for the patient. If we look onto the caregivers, actually, we think that they had a blessing in disguise in the form of lockdown coming in, and they would find time to be with the people in their homes. But it was indeed a challenging experiences for them, because definitely COVID put in its own changes being brought about, and we know that people with dementia have difficulty in adjusting with the changes which happen so fast. So all the challenge was to be taken up by the caregivers, which will result in physical, mental, emotional, and financial stresses occurring in the individuals. The service providers in the healthcare system, we're happy to see that the Ministry of Health and Family Welfare had published a health advisory for the early population very early in the lockdown itself, which gave trophy passes to the individuals so that the caregivers could access essential services at the time of curfew also. WHO has also developed an eye support system which addresses to the caregiver's role in caring for the patient. The Department of Clinical Psychology, the Neuropsychology Unit, has developed a cognitive training program, which is which has been digitalized into an app called as Agile Mind, which is used for training, the cognitive training of the people. Such services are being provided, but it is to be looked into that. The services get focused into certain areas only. In a country like India, which is so large, with a massive people of people residing in the rural area, how far the telecommunication facilities or digital facilities can be accessed by these people becomes a real challenge for everyone. I'm very proud to say that we have eminent speakers with us to deal with these topics, and I feel that they will be handling this topic and deliberations which takes place after this will be very useful to all the participants. I'm very thankful to all the participants. We have more than 600 registration taking place for the webinar, and it is indeed very encouraging for us, and it is a motivation factor which keeps us moving. Thank you all for coming in and participating. Thank you all speakers. Thank you the management, Director and Karedan and Jerry for being with us and supporting us in our venture. I hereby feel that it's time for us to hear with the deliberations which has to come up with the experts. Thank you very much.
Thank you, ma'am, for the information you have shared. Now I request Mrs. Minnie Matthew to moderate the session.
Thank you, Mrs. Divya. Good morning to all. I'm Minnie Matthew, lecturer, Lisie College of Nursing. On behalf of Principal and Faculty of Lisie College of Nursing, once again I welcome each one of you to this webinar on impact of COVID-19 on Alzheimer's disease and related dementia. I would like to give few instructions to the participants before beginning the session. Kindly keep your microphone in mute mode throughout the session. If you have any questions during the presentation, please type them in the chat box. Moderator will forward the questions to the presenter and will be answered at the end of each session. Link for feedback form will be shared in the chat box at the end of the last session. Please enter your details correctly. Same link can be used to join the session tomorrow on 22nd September. We have a wonderful person, Dr. Ajla Dektu Gaikwad, to talk to us on challenges and risks for people with Alzheimer's disease and related dementia during COVID-19 pandemic. Dr. Ajla is Associate Professor from Himalayan College of Nursing, Swami Rama Himalayan University, Dehradun. She is interested to work with children with emotional problem and also enjoys her role as a teacher. She is very active in nursing research too and has many publications to her credit. We welcome you, Dr. Ajla, to the session. Over to you, ma'am.
Thank you, Mary ma'am. I'll start my screen sharing now.
Yes.
Yeah. Okay. A very good morning to everyone present here. I'm very happy that Lisie College of Nursing has taken this initiative to deal with this vulnerable population and address these issues at the right time. So basically, and I would like to thank all the organizing committee members so that they have given me the opportunity to discuss on this issue. So I'll be talking about impact of COVID-19 on Alzheimer's disease related dementia, challenges and risk for ADRD patients. Just give me a moment. I request the participant to avoid scribbling on the screen. Okay, so to continue, the Alzheimer's disease related dementias and these are the commonest variety of forms of dementia already discussed by Dr. Usha. The dementia likely affects more than 47 million people worldwide, and in Indian scenario, it is almost about 5.3 million people have some form of the dementia. The Alzheimer's disease is an irreversible progressive brain disorder that slowly destroys memory, thinking skills, and eventually the ability to carry out the simplest task. Alzheimer's is the most common cause of dementia among older adults. The commonest signs and symptoms already discussed, but I'll just throw some light on few issues. In addition to the memory loss, symptoms of Alzheimer's include trouble in completing tasks that were once easy, difficulty in solving problems, changes in mood or personality, withdrawing from friends and family, problems with communication, either written or spoken, confusion about places, people, and events, visual changes such as trouble understanding images. These are the common symptoms which are seen by family and friends in the beginning, and later person may himself notice that these changes are happening within him. So if we focus on the common issues which are seen with these patients are basically inability to recall things, inability to register new things. And when they find it difficult, we see that in current scenario, every day each guideline or each actions which are taken are being changed and new normal has been set. So it becomes very difficult for these people to register new things and recall whatever things have been registered. So this Alzheimer's disease is actually named after Dr. Alois Alzheimer. In 1906, Dr. Alzheimer noticed changes in the brain tissue of a woman who had died of an unusual mental illness. Her symptoms included memory loss, language problems, and unpredictable behavior. The common risk factor already discussed, like age is the important risk factor. With increase in the age, the symptoms of the Alzheimer's disease goes on rising. Family members with Alzheimer's disease, genetic predisposition, having mild cognitive impairment, these are another genetic or chromosomal factor which have more impact on the dementia. The cardiovascular disease are supposed to reduce blood flow to the brain tissues and cause further damage to the nervous structure and causing further increase in the symptoms of the sign dementia. Education and Alzheimer's, there are some studies who are quoting that the formal education is associated with more cases of Alzheimer's dementia, whereas increase in the education increase the neuronal network connection and thereby reducing the risk of dementia. Traumatic brain injury, repeated traumatic brain injury can also cause nervous tissue insult and cause further damage to these patients. If we go gross microscopically, during the preclinical stages of Alzheimer's disease, people seem to be symptom free, but toxic changes are taking place in the brain. Abnormal deposits of protein form amyloid plaques and tau angles throughout the brain. Once healthy neurons stop functioning, lose connection with other neurons, and then die. Many other complex brain changes may happen along with. The damage initially appears to take place in the hippocampus and entorhinal cortex and parts of the brains essential in forming memories. As more and more neurons die, additional part of the brain gets affected and begins to shrink. By the final stage of Alzheimer's, damage is widespread and brain tissue has shrunk significantly. If we see the images of brain, this is the healthy brain without any disease, and this is the brain scan of brain with advanced Alzheimer's. If we compare both of them, you see that there is significant shrinking in the neuronal tissues of the brain, and hence the functioning also gets affected. There are several stages of Alzheimer has been discussed. Some classification includes only three categories: mild, moderate, and severe. But I found these seven stages, which are described by Reisenberg system, has more description about the problems which can be addressed easily. So the stages are divided into seven. First is about no impairment. Second is very mild decline. Third, mild decline. Fourth is moderate decline. Fifth is moderately severe decline. Sixth is severe decline. And seventh is very severe decline. The previous classification does have merging of second and third stage into mild decline, fourth and fifth stage into moderate decline, and sixth and seventh into severe dementia. So what exactly happens in this individual stage? Stage one is of no impairment. When actually person does not show any sign and symptom of Alzheimer's or dementia, it is not detectable clinically. But you may see the brain changes or neuronal changes like what we have seen in the previous slide that happens, or that is underlying pathology is being existent. Second stage is a very mild decline stage, wherein minor memory problems or such as losing things around the house, and even though patient is doing well on memory tests, and the disease is unlikely to be detected by loved ones and physicians. So that is very beginning phase of the memory decline. Third stage is about mild decline, wherein family members and friends of the senior citizen may begin to notice cognitive problems, and performance on memory tests are affected, and physicians will be able to detect impaired cognitive function in the patient. Fourth stage is moderate decline. Here, clear-cut symptoms of the disease starts appearing. Fifth stage is moderately decline. People begin to need help with many of the day-to-day activities because they are not able to focus on, they are not able to recall the task. Sixth stage is needing constant supervision and frequently requiring professional care. And very severe is totally dependent, sometimes totally dependent for their activities of daily living and inability to communicate or respond to their environment. So these are the basic seven stages of dementia, Alzheimer's dementia. Now, how does this diagnosis happens? Basically, collecting thorough family medical history, a thorough neurological examination, conducting cognitive test to evaluate memory and thinking, doing blood tests to rule out other possible causes and symptoms, and brain imaging. These are the diagnostic criteria used for Alzheimer's disease. Now, moving on actually towards today's topic, that is COVID-19 and Alzheimer's disease, how it has impacted. I think almost each one of us is facing some or the other problem because of this COVID-19. The shape and form may vary for us and the dementia patients. As Dr. Usha already discussed, that every day there is a new normal has been set, right? Example, even if when you're coming to office, usually your routine was only carrying your regular stuff for the duty. But these days, when we move to hospital or we go to any larger gathering, what things we need to keep in mind is always wearing a mask. Sometimes even you're using face shield or some personal protective equipments in different areas depending on the requirement. So this is the new normal set currently. So even sometimes it becomes very difficult for us to remember what we have to carry with us every time when we are going to XYZ area. So that becomes difficult for healthy individual. Just imagine what can happen with this dementia clients. So we'll see what exactly does this COVID-19 pandemic. Actually, this COVID-19 pandemic is causing global morbidity and mortality, straining health system and disrupting society, putting the individuals with Alzheimer's disease and related dementias at higher risk of significant harm. Does it say that Alzheimer's dementia caused COVID-19? It's not like that. Dementia doesn't make people more susceptible to COVID-19, but certain related behaviors may increase the risk. Example, People with dementia may forget to wash their hands or take the recommended precautions which have been set every day, or which have been set for prevention of this infection. We'll just have a quick glance at a video. What problems are commonly faced by this individual? In case if it is not audible, organizers, please let me know about it. So,
hello and welcome to this video on meeting the needs of people with dementia who live in care during the COVID-19 pandemic. Staff in care homes are already aware of the importance of trying to meet the needs of residents. For example, helping them feel safe when they're scared or providing them something meaningful to do when they're bored. By meeting people's needs, we help maintain a good quality of life and sense of well-being. There are 8 fundamental needs that all people share. And these needs are physical comfort and freedom from pain, a need to feel safe and secure, not wishing to feel vulnerable, a need for love and a sense of belonging, a need for self-esteem, to feel valued and treated with dignity and respect, a need to feel in control over oneself and the environment and have choices respected, a need for meaningful physical touch, for comfort and reassurance, a need to have fun, to play and to laugh, and a need for meaningful occupation to give us purpose and entertainment. This video will highlight the difficulties of meeting these needs during the COVID-19 pandemic. We'll discuss why each need may be more difficult to meet, and then see how some care homes have creatively tackled the issue. Let's start by looking at physical comfort and freedom from pain. Many older adults are already suffering from muscular, skeletal, or dental pain, but further discomfort may occur due to reduced daily exercise. Fewer visits from healthcare professionals may also result in a spike of undiagnosed pain. The need for safety may be difficult to meet, as residents with mild dementia may be very aware of the pandemic and of friends who may be ill. Others may be scared by the use of PPE, increased restrictions, and the loss of support from friends and family. Understandably, this will be an extremely frightening time for many residents. Many residents like to have physical touch for comfort and reassurance. Holding someone's hand or offering a hug can often go a long way to helping someone feel better. Because of the pandemic, this is reduced or can only happen via the use of PPE, and many residents will find this change difficult. We want to foster positive relationships between residents and for them to feel part of a family or community. As the pandemic requires people to remain separate, it has prevented many of the strategies used to create this sense of belonging. Self-esteem needs are still met in some ways, as staff always treat residents with dignity and respect. However, the pandemic has reduced staff numbers and created a lot more work for staff, and many care homes have told us they can no longer spend as much time with each resident as they would normally like to, meaning interactions with staff may be shorter. Fellow residents who they chatted with often and made them feel valued may also be less available. Loss of freedom and sense of control is a major consequence of the restrictions brought in. Residents are less able to meet in social groups and may be asked to stay in their rooms for long periods of time. Need for control is an extremely strong drive, and this may lead to increased conflict and agitation. It has been hard to meet the need for fun now that the usual entertainment care homes provide has been more difficult to carry out. Some residents are especially missing their weekly visit from the hairdresser. Being occupied and active is important for both our physical and mental health. Due to distancing measures, residents are less able to carry out activities where they need close support or prompting. Daily visits outside the home have also stopped, leaving residents feeling unoccupied and bored. As you can see, COVID-19 restrictions have created a clear threat to residents' well-being, but staff have been very inventive when tackling this issue. The following are real examples from care homes across the UK.
okay. If you just have focused on the video, it has addressed very trivial issues like what are the daily needs of this individual are not being met properly, and that causes major trouble to patients with dementia. So there are many research studies have come up within this shorter duration of time and have given many association like what are the factors which are affecting people with dementia. The first association was found: there is increased risk of infection in people with dementia and older people. We say that along with aging, there are many systems which undergo degenerative process, or what to say that because of aging, the functioning becomes a little slower. And along with that, the patients with dementia, due to loss of memory or inability to recall with the things, they are at high risk of developing further infection. Second thing is association was found, like increased risk of poor outcomes in older people with those with dementia. And third was adverse impact of COVID-19 upon the brain and their cognition, leading to further damage and degenerative process. So now this COVID-19 has imposed challenges and risks to not only patient, but along with them, their caregiver, as well as the healthcare professionals. So, and when we come to hospital scenario, or what we say that healthcare delivery system, the challenges are commonly faced in the hospital, inpatient setting, outpatient setting, care homes like assisted living facilities, nursing homes, and community dwelling people with dementia and informal caregiver. So the challenges and risk, if we start on discussing in depth what exactly they face, first is individual with Alzheimer's dementia are at high risk for COVID-19 and its associated morbidity and mortality. In one research study, it was found that more than 90% cases which were found in aged people were from the category of dementia. COVID-19 will, so second point is COVID-19 will impact diagnosis and clinical management and of these dementia patients. This imposes another challenge. Third is the impact on societal response to COVID-19 in different stages of dementia in different care setting. The impact of COVID-19 on caregivers and physicians of individuals with dementia. Mental hygiene, trauma, and stigma in the time of COVID-19 is another challenge which we need to take care of. And the last is the potential impact of COVID-19 that is just hypothesized on research. This researchers may threaten the patients of tomorrow. The first challenge when we talk about individual patient, some individual with Alzheimer's dementia may be unable to follow the recommendations from public health authorities to reduce the transmission of COVID-19. Though this information is very trivial, for us it is like simply, it is just hand washing, covering our mouth while sneezing or coughing, monitoring and reporting the symptom of COVID-19, maintaining physical distance from each other, and self-isolation by remaining alone at home. So it has become very difficult for even normal individual to remember these all things. You just imagine the condition of patients with dementia. Then decline in their health status due to social isolation. So when we talk about health, it is not only the physical health, but it is all about the mental health and social health of an individual as well. The separation from family and friends during the pandemic can escalate dementia-related behaviors, including confusion, wandering, and aggression. And when you say that when these patients are having confusion and wandering, it becomes further difficult to go for the social isolation. Now, because of social isolation, you will see the video also reflected the same thing. Because the person is not able to interact with people around, there are high chances that they may have ineffective coping and land up into depression and anxiety, which are increasing risk of cardiovascular, cognitive, and mental health problem can be associated with this isolation. Cognitive impairment may impede communication, especially virtually, thus further contributing to social isolation and potentially causing more rapid cognitive decline. The other problems associated are milder dementia may be unwilling or unable to comply due to apathy or depression. Those with more severe dementias will not be able to understand, appreciate, or remember most of this recommendation due to severity of their short-term memory loss and overall cognitive impairment. Finally, the behavioral and psychological symptoms of dementia, such as motor agitation, intrusiveness, or wandering, may undermine the efforts of maintaining isolation. Individuals with dementia are more likely to have cardiovascular disease, diabetes, and pneumonia compared to the individuals of the same age without dementia. Poor outcomes, including death. Already I discussed, like there are few studies which indicated that the geriatric people of age 80 years and above have a risk of 12-fold more than that of the general population, whereas those they are between age group of 50 to 70 have double the risk of getting the infection. It has been found through researchers that pneumonia was identified as one of the possible cause of death, and the occurrence of death due to pneumonia associated with dementia was expressed as an odds ratio with 95 confidence interval. The other issues and challenges which are witnessed, they are in the diagnosis and clinical management of the patients. So we see that, okay, the patient is already having the problems, but they're not able to reach the hospital. In the beginning phase of the lockdown, it was really difficult for the people or general population to take care of their health issues because of shortage of hospital beds and strain on the healthcare providers, diversion of resources away from patients with the chronic disease, including those with the dementia, suspension of elective and non-urgent care due to COVID, and availability of urgent and intensive care resources become compromised when prevalence of severe cases of COVID-19 happened, which exceeded the local resources. And primary care providers and specialists were being redeployed to address the medical emergencies. So the patients with dementia could not meet the healthcare requirement through the general healthcare setup. So these were the common challenges which were faced in the diagnosis and clinical management. There are many other issues which are faced in the healthcare setup. I think the next speaker may talk about it. There are many models also have been brought up so that the dementia patient will receive adequate treatment and management at home setting through use of the telecommunication system. So what needs we need to focus on is people living with dementia or informal caregivers should focus basically on control of the infection, care of the basic needs, calming down and down the challenging behaviors, and comprehensive cognitive enhancement, clinical management of the cognitive disorder at house level, and concerns for the credits to the caregiver, because it becomes difficult for caregivers also to address the issues which are faced, and every day they will meet with some or the other challenges. So the healthcare leaders have to act as a liaison between community-based services and the social support network. So basically to increase the society's awareness of the needs of people with dementia and caregiver, and to initiate discussion or projects of how to support these people with dementia and their caregivers. So there are different models also are there. I hope the subsequent sessions will address this all things. Just to conclude, the global impact of COVID-19 is unprecedented, and particularly on vulnerable groups such as people living with dementia and their families and caregiver. The situation changes daily, and we need to share resources and best practices guidance as they become available. As we say that every day new information has been added by WHO, CDC guidelines, and Ministry of Health and Family Welfare. So we need to be aware. Being the healthcare professional, we have to be aware about these changes, and we'll have to incorporate this into our daily practice. So my session was basically to focus on what are the challenges, what individual is actually facing. We will over period we'll see what are the challenges which are faced by the family members and healthcare setup, so that we get geared up to deal with these all challenges and help them to achieve this all through all problems, or deal with this all problems through our advanced care plans or advanced directives. And families can make informed decision about how and when and where to seek for help. So that was all about the challenges which are experienced. For further reference, if you want, you can go through the links which are given here, and let's work together to enhance the well-being. So that was all about my presentation on challenges which are experienced by this patient and patients. I hope you're clear with the part. If organizers, if I have some little time, I can show one more video on what needs we have already discussed, how briefly they can be handled.
Yes, ma'am, surely. You can proceed with.
Yeah, thank you. So we'll just have a look at what are the problems we had look at what were the problems which are experienced by these people, and how with our minimal interventions that can be dealt. I'll just continue with the same.
A threat to residents' well-being, but staff have been very inventive when tackling this issue. The following are real examples from care homes across the UK. To meet the need for physical comfort, when appropriate, residents are encouraged to keep active and make use of the garden whilst maintaining their social distance. Staff politely separate residents who are walking too closely together. Staff are also being extra vigilant for signs of pain and discomfort, now other healthcare professionals are less present. To meet the need of safety, many homes are keeping in regular contact with chaplains and other religious leaders, offering services over the internet or one-to-one. Some homes told us they encourage regularly washing residents' hands, making them feel safer and also providing a form of positive touch. When wearing PPE, staff are encouraged to wear washable photographs of themselves so residents can still tell who they are. To meet a need for meaningful touch, some care homes have been using therapeutic dolls and soft toys, which have been shown to have benefits for some, but not all residents. One care home told us how they are using no-rinse shampoo and conditioner caps, where residents can have their hair washed and have a gentle massage from staff. This allows residents to feel pampered without having direct physical contact. To give residents a feeling of love and belonging, care homes have been using technology to allow residents to video call their friends and families. Where this is not an option, staff are going through photo albums with residents and encouraging them to write cards and letters. Some care homes are also taking advantage of schemes like Adopt a Granny, where volunteers make regular contact with older people. As we said, staff are always meeting self-esteem needs by treating people with respect. But an important aspect of self-esteem for many residents, looking their best. Having their hair done, for example, a blow dry, can go a long way to making residents feel good about themselves. In order to give residents a sense of control during COVID restrictions, one care home told us how they gave cleaning equipment to residents so that they could keep active and maintain their bedrooms to their own standards. Another home said they were keen on staff taking extra time to introduce themselves and ask if it's okay to enter residents' rooms, and give the reason for wanting to enter, again giving residents a sense of control over their own space. Homes have been highly inventive when making sure residents have fun. We've seen activities from TikTok videos to exercise classes to Easter bonnet competitions. We've seen entertainers perform remotely and from a distance in the garden. A lot of these activities meet multiple needs, which is obviously a good thing. Finally, almost all care homes said it was essential to meet the needs of their staff. They expressed great amounts of pride for their staff, who are showing extremely high levels of care and resilience whilst working in incredibly challenging conditions. Here's a quote that nicely sums up the view of a regional manager. It's important staff feel safe and secure. In 2 homes with outbreaks, I've seen the same reaction by staff as it unfolds. They're very anxious and frightened and need a lot of emotional support. They begin to see deaths in quick succession, and are sad as these are usually people they've cared for a long time. We set up a chill room in one home in a spare lounge. We put a mindfulness CD and some battery-operated candles and flowers in there, and told staff to take a 5-minute break when they needed to. It was only used a little initially, then staff seemed to adjust. They felt cared for and supported. Thank you for watching this animation on meeting the needs of people.
Okay, that was all about the needs of our patients who are having dementia and what are the common problems they are faced and how we can deal it very effectively with minor interventions. We just have to modify and have to think innovatively. The way it has imposed challenges to the patient, it has imposed challenges to all the healthcare providers too. So with that, I conclude my session. In case if there are any questions or queries, I can address that.
Thank you, ma'am, for your informative session. We really enjoyed your presentation. So we have no queries from the participants yet. So once again, on behalf of everyone here today, I thank Dr. Ajla for taking the time from her busy schedule to talk to us about the difficulties and risks ADRD patients face during this COVID pandemic. Thank you, ma'am. Thank you very much.
Thank you.
With this, our first session is over. Let us move on to the next session. Now, Dr. Bindu will speak to us on challenges for mental health professionals. Dr. Bindu Jose works as a mental health practitioner, Teros Health, Arizona, USA. She has vast experience in working with mentally ill patients and mental health professionals in various hospitals in US and Middle East. We welcome you, ma'am, to the session. Over to you, ma'am. Madam, can you please unmute? Okay.
Good morning, everybody. I hope you can hear me.
Yes, ma'am.
Thank you, Dr. Ajla, and thank you, Lisie team, Dr. Usha, Ms. Manju, Ms. Minnie, and the whole team. I know there is a lot of hard work behind it. And I'm going to talk about the mental health challenges faced by mental health professionals and also social service professionals during this COVID-19. It has been, we have never seen anything like this, not our generation or our parents' generation. Actually, the word pandemic or epidemic was kind of a look-up word for even medical students for the clarity of meaning till 2019. And when it became 2020, even kindergartners know what is a pandemic, what we are going through. So a drastic change in the world, how we look into, our daily life. So basically we are starting with a mental health setting, what professionals are there, what we have been seeing in the clinics, how the mental status of the patients and also the professionals changed during this pandemic time. Before going there, I just want to address more than 30 million cases have been confirmed globally, and death toll passed 950,000. And there was a survey in May of 2020. They reported that more than 1,000 healthcare workers died because of COVID-19. Many countries are not really reporting healthcare workers' death because they don't want to increase the distress among healthcare workers and to the general population. So I do work in a outpatient clinic. We do have almost 2,000 mental health clients, and we are 7 providers, 4 providers are psychiatrists, and then we have 3 nurse practitioners. This is nurse practitioners with a specialty in psychiatry. So we see almost 2,000 clients in a time period of 3 months. So pretty much outpatient from 7:30 in the morning till 5:30 in the evening. So our clinic is a severely mentally ill clients clinic. So we do have a lot of case managers working with us and clinical coordinators. Basically, they are the team leaders of case managers of 12 to 15 case managers. Then we do have social workers, counselors, therapists, medical assistants, psychiatric nurses, then psychiatrist providers, directors, rehab specialists, pharmacists, students and interns, and also coordinators like the front desk staff to bring the clients in for different services. And we do have care home managers and staff. Most of our clients, because of their cognitive delay, they are schizophrenic or mentally ill for a long time, the cognitive abilities are declined, and they are in care homes, just like the dementia clients. Some of them are together too because the psychiatric symptoms overlap with dementia. Dementia symptoms overlap with psychiatric symptoms. So we do have a lot of our clients from care homes, and they are part of our staff too. Now, I just want to bring your attention to a banner we have seen 2 months ago when we were driving through the neighborhood. There was a big banner stating "Heroes Work Here." So I was kind of curious why I had not seen these statements or banners anywhere before. And my husband told me it was because 15 residents from that care home died because of COVID just 2 months ago. So the staff there were shocked. They were in an emotional toll. They didn't know whether they carried the disease to the care home or they are taking the disease to their family members, the emotional toll they have been gone through was tremendous. So that's why when Manju Miss is my tutor from Little Flower Hospital, India. So when she asked me to present about the mental health professionals challenges during this COVID-19, I kind of instantly agreed because it was really making me emotional too. So we have a lot of clients, as I mentioned to you, dementia homes, psych care homes, old age homes, homes for disabled kids and disabled adults. They bring the clients to clinics inpatient and we do care for them. So now the problems we encountered related to COVID-19 outbreak, our numbers were almost per day 6,000 cases plus during the last 3 months. So I don't want anybody in India getting panicked because our population, when compared to one state in India, is very low here in Arizona. But our numbers of COVID positive cases were really, really high, skyrocket during July, August. September, we are coming down to almost like a 600, 700 cases now. So, you know, we go through that big peak and we will calm down. So nobody needs to be panicked, but we need to do a lot of things to bring it down, that curve. So the mental health concerns we have seen increased anxiety and depression. It was in general population, it was among mental health population, and it was also among the healthcare professionals. Disturbance in sleep pattern and insomnia was the second major problems we have encountered. There was also a lot of increase in numbers of panic disorders, phobias, OCD, generalized anxiety disorder, and also PTSD. So there is increased depth of depression, especially in major depressive cases, and also prolonged depressive phase in mood disorders, including bipolar disorder. There is also a lot of increase in the cases substance use disorders and also substance-induced disorders. There were many cases, there were substance-induced psychosis. The first time psychosis happened during this pandemic time because they didn't know what the other outlets are, end up using drugs and having the psychosis for the first time, especially youngsters, teenagers. Now, schizophrenic clients, other psychotic clients, and dementia clients, they are not as affected by the pandemic as compared to the general mental health clients. There were few incidents they reported like increased aggression and delirium and those kind of increased symptoms. But when we researched about it, mostly it was transference of, you know, the workers, those who were caring for them were stressed out too much, end up missing the medication doses. There are other factors which was directly causing the aggression rather than COVID-19 itself. But definitely, as Dr. Achla mentioned, lack of awareness in this population and difficulty to make them wear the mask or to do the protective measures like hand washing, and they don't understand the basis of why we are doing it, why they are forcing us to do it. So that it increased the stress on
Sorry for the network issue. Please stay online. We will resume soon.
Can you hear me now?
Yes, ma'am. We can hear you now.
Okay. Where did we disconnected when I was talking about the dementia clients? That's where we got disconnected. Did
Yes,
you
ma'am.
hear that portion or no?
Yes, ma'am.
Okay, so that was from direct experience I was talking about. I went through a couple of research studies and also a literature review. And I've looked for, these are the same problems they encountered. They were recent research around the world. They also found increased anxiety and depression among healthcare professionals, increased sleep disturbance. Then it was mainly related to epidemiological issues related to not knowing whether I am positive or not. Am I carrying the virus and giving it to my family members? Those kind of issues were worrying them. Then there were lack of material resources. You would think when considering US that we would have all the equipment we want, all the protective materials. No, we were scarce. We didn't even have masks when our numbers were on peak. But luckily, they prevented it really, the prevention program was really going through. So we were able to stretch it out and able to get the material. So material resources lacking was a fear on the healthcare professionals' mind, even to go for work. Then human resources, there was, when the cases were really high and the hospitals were full, and also the ventilator capacity was almost full. So, when the staff get sick, that's when the mental trauma was too much. They really, some of the staff, they were not really symptomatic, but they are home, they feel like they have to go for work because the facility needs them. So if our numbers also going to go high, we are going to really feel the shortage of healthcare professionals. So we have to prevent this so that we can have enough care workers, taking care of the people. So these are all the aspects caused increased stress and distress in the healthcare professionals. There were personal factors too, and unexplored variables, including, for example, if a person working in the healthcare field, doctor or nurse or case worker, they are working for 8 hours, but because of the increased number of patients, increased stress going through, they end up stretching their hours to 10 hours, 12 hours, coming back home, and if they don't recover, don't sleep well, then their stress level is further increased to a level like they don't feel like they can work for tomorrow. So that was the main problems when I was going through the research studies too. Let's go to the next slide. So in this stress, we are all sure that the anxiety and depression level is going to be high, and the distress level of the working professionals are going to be on the roof. So we need to practice how to address this distress, how to calm ourselves down and take care of the clients who are, given to us to make them feel better. So acknowledging your emotions are first step. We are very good to tell this to the clients and teach them, but we are not really good for practicing that for ourselves. So if you're feeling depressed, if you're feeling guilty, feeling angry, sometimes feeling heroic, like I'm fighting against COVID, I'm preventing it. So there could be a mixed emotions during this pandemic. So we have to acknowledge, my main way of telling to my faith, my Jesus, that Jesus, I'm feeling stressed out in the situation. I cannot handle this many increased anxiety clients. So you have to help me. Kind of a self-talk to calm myself down. And at the same time acknowledging my emotion that I'm getting anxious. So I needed to be taking care of this particular client whose anxiety is on the roof and they're having a panic attack. So acknowledging our own emotions and calming ourselves down is very important while you're handling a distress situation. And then express your emotions to the people you trust, not to the people who are also panicking. That's not the best way to address your emotions. So use your friends, family, then the technology, use it, use the FaceTime, talk to your friends, and keep your connections, okay? There were some people, some healthcare workers, there were downtime too because their department was not working, but they are not prepared well to take care of the COVID clients. So there were downtime for some of the healthcare professionals. So they were recharging and they were getting training to take care of this COVID population in a different way. For example, those who do not have symptoms and things like that. Now, clarify uncertainties from reliable sources. That's another technique, we don't want to go and watch the news channels 24/7. I'm not against CNN or I'm not against any news channels, but having news from all over the world and tragic news all the time, it's not a helpful thing to resolve your stress. Then eat and drink healthy. That's a simple technique. We all do it, but sometimes in case of when we are busy, we forget to do that. Find time for exercise and relaxation. Practice mindfulness. Yoga is a very good technique, full of mindfulness. You can do some simple sessions even in between, like a meditation or prayer in the beginning of the work, in the middle of the work, when somebody passing away or somebody, your own coworker is getting sick and on ventilator. So practicing mindfulness, small meditation sessions will be really helpful for you to manage during this COVID-19. Now find new hobbies, observe nature or animals, practice healthy habits. If you don't have healthy habits, you can learn some through the internet or use the technology. They were our helping friends during this pandemic to a great level rather than we expected. Then read Bible, Bhagavad Gita, Quran, or good books. If you're isolated, self-isolated, quarantined, for sure, books are going to be your best friends. Okay, now I'm going to present some daily challenges we encountered during our practice. This is from my own teammates. First, I have Dr. John Allison. He's our director of our Behavioral Health Institute. So the challenges he experienced during this COVID-19 is balancing patient and staff safety. That was his big concern. Staff were kind of afraid to come in for work because our population, some of our clients were homeless. They wander around. They don't take care of their physical health. So when they come in, people or the staff were afraid that they carry the virus or not, and we didn't have testing availability during that time when the COVID was at peak at the mental health clinic. So it was a big challenge for him, but he followed the local and federal guidelines for operation. We have CDC, Center for Disease Control and Prevention, giving us clear guidelines, what clinic needs to have, what kind of facilities or what kind of provisions for safely working. So he followed that one as a solution. Now, continuing care for patients remotely, we used a lot of telephone sessions and also telehealth session with video. We didn't have training for tele sessions for the regular providers, but we got some small training during that time and we practiced, and now we are doing it, actually doing it really well. Now, managing remote and in-clinic staffing of providers. So nobody wants to be in the clinic all day and 5 days in a week. So he rotated the providers. We need to have some providers in clinic because we have, as I mentioned before, severely mentally ill clients. Our clinic is their home. So when they get confused or their symptoms are really worse, they come to the clinic no matter what. They don't care whether it's COVID, they do have to wear mask. They don't care about any of those factors. They will come to the clinic. So we need to have some providers in the clinic every day. So we rotated 1 week, half of the providers in clinic, and the other week they can work from home. So we rotated those areas of work. Now I have Teresa. Okay, Teresa Porter, she's our clinical coordinator, meaning that she is the team leader for 12 to 15 case managers. So what they do is that they do home visits. They make sure these clients are safe, those who are living independently, and case managers. So she met with a lot of case managers who are scared to work, especially to go and do home visits. So she allowed the staff to do what they are comfortable with within reasoning. Okay, if there is a reason, if somebody is already having symptoms, they didn't have to go to the home visit, but they did like a phone check. But if nobody is COVID positive or no reason, no symptoms for that family, she let them go to the do the home visits and stuff. Then schedule changes. She always had schedule A and B. For example, if that particular day she needs 10 case managers, she also planned like if 5 of them didn't show up, how do I manage with just 5 case managers for the day? Now, keeping members and staff safe, that was a concern for all the team members. And we limited face-to-face time using telehealth more, and the stable clients, we let them stay at their house and have the appointments over the phone or telemedicine. Now I have Michelle Stelmatch. She's our work rehab specialist. She trained our clients to for job training and also prepare them for going for interviews, getting job. And she met a lot of clients. She told me that she herself felt so much isolation, increased anxiety and depression. Same with the clients too. So she scheduled a lot of WebEx meetings, and then she distributed handouts and list of ideas for how to cope during this isolation. And she watched a lot of YouTube videos. She told me Dr. KJ Foster, if anybody is interested, that's a famous doctor who is managing a lot of substance abuse mental health clients. And she has a lot of inspiring videos in the YouTube. You can use it if you are interested in mental health and substance abuse treatment. Now, phone appointments were also used by her. Now, I have Kayla Button. She is my medical assistant. She usually checked the clients in and check their vital signs. Also, she gave clients injections and labs. Because it's an severely mentally ill clients clinic, we do a lot of long-acting antipsychotic injection for our clients because they forget to take their oral antipsychotic medication. So they are required to come once every month. Some medications are available once every 3 months. So convincing that clients to come to the clinic during COVID-19 peak was kind of a trouble. So they were getting more psychotic and symptomatic. And then she explained to the clients the safety protocols used in the clinic and also offered different routes to come to the clinic. For example, our lobby is usually crowded, so we took the back door, side doors to bring them in, so they don't have to get exposed to the many clients sitting in the main lobby. And then there was also an influx of missed appointments due to confusion. Clients don't know whether to go or not. So they missed appointments, increased symptoms, so they needed extra appointments. And so she tried to get patients the soonest available appointment and clear up confusion, sometimes short telephone appointments to bridge the medications. That's what she used for that particular challenge. Then there was a lot of calls, increased calls from the clients for increased anxiety, depression, and they wanted to increase the medication and to change the medication. And she addressed that with the available doctors of the day, and we had short-term plan and then having an appointment earlier. Now, Shari Borgeson, she is a licensed counselor, professional counselor, mental health therapist. She is a real gem of the team, I would say. There was a lot of clients requiring more therapy sessions and also counseling. So instead of doing counseling for 10 clients in a day, she ended up doing 20, I think. She was all in the clinic. So in-person appointments, she provided them no matter what the client was coming with, even when they were not able to wear the mask. She allowed them to come in and talk to her because she kind of felt their isolation and the need for in-person counseling. Then she wore a mask for sure. Then less ability to use outlets. That was the main complaint from her clients. They cannot go to park, they cannot go to gym or gatherings because everything was closed during the lockdown. So she conducted some support groups and taught them some activities to do at home. Then not able to go to church, community gatherings, that was a big component of social life. And offering in-person appointments are her solution. at least she being available to that clients. That's what she did as a solution. Then she also struggled with the absence of facial and non-verbal cues, especially doing a telephone appointment. It's hard to say a depressed client telling you that I'm depressed, but I'm able to manage. But if you could see them, you would know that whether they took shower during that week, whether their personal hygiene, how they are looking like. So we missed that piece for the telephone appointment. So we end up using the video sessions more to have more clarity of assessment. Now we have Jo Ellen Fisher. She's our psychiatric nurse. She's a psychiatric nurse for more than 35 years. That's her passion. So lockdown group homes, especially same type of dementia group homes we have for psychiatric clients. It's a mixed population also there. Clients were unable to come to clinic for injections and labs. That was a big, and they don't have professional staff inside the care home to give the injection. So what our nurse did that, she wanted the doctors to change to oral medication for temporary use till the lockdown situation is over. We did that. Then she also went to these care homes with the protective measures, and she gave injections just in their front lobby or outside. So she is really passionate about what she's doing. Now, no supports available for clients, so she ended up giving a lot of phone call appointments and video sessions with clients. No structure during the day for psychiatric clients. So exploring options with the clients for daily routines and structure, teaching them. Here in US, we also do like nurse appointments. So clients can come to the nurse for a 30 minutes, 1 hour appointment. They do a lot of health teaching and simple teach the clients a lot of measures to calm down their anxiety and stuff. So she did a lot of sessions too. Now, no access to phone. There are clients, they didn't have smartphones, so they cannot use the video session. And sometimes they miss their phone, they cannot find their phone. So we provided transportation to come to the clinic and use the phone from the clinic, and also the video access from the clinic to meet the other providers. There are some insurance companies, they did a smart thing. They provided the clients with some smartphones during this time, also provided with tablets so they can have video sessions with the providers. I think that was a very wise idea for them for future too. Now, high-risk clients contracting COVID. For example, if the clients are telling me, I have a cough for a few days, I am having some fever, but I need my medication. So we restricted their in-person visit. We decreased the clinic visit, and we also, took them to facilities where they can do COVID testing and do both psychiatric and physical health care there. Then also pharmacy did a great solution. They did deliver the medications through mail deliveries, so the clients don't have to come to the pharmacy. It was delivered, the medications were delivered to their house or mailbox. We just need to prescribe through the computer, and that goes directly to the pharmacy. From pharmacy, it goes directly to the client's house, so they don't have to get out to go to the pharmacy or to the clinic. Now, the other challenges, this is a case manager, Sergio Mentes. Clients were dealing with loneliness and isolation. So he called the clients more often and provide supportive listening. And discharging clients from hospital during pandemic was a stressful situation for him, because they are required to have a case manager accompanying these clients to the particular homes. Sometimes they go wandering and they got missing. So, and completing home visits are completed outside the client's door. So that's the solution for, scared to go inside because we don't know whether they have been exposed to COVID or they were carrying the virus. So now, this is my own challenges. It's actually kind of a mixture of what they experience. So I'm not going into detail, but there is a lot of increase in anxiety and depression in clients. So I referred them for more therapy, counseling, And I increased my sessions. We can usually take 10, 15 minutes or 20 minutes, 30 minutes, depending on the need of the client. So many of the sessions got increased. So increased length for the sessions, number of appointments increased. Now, yeah, even though I try not to prescribe too much medication for anxiety and depression, not to increase too much medications, I end up increasing the dose for some clients. There is no other way I could calm them down. So medication dose is increased. Now, increased number of positive cases in our own client population. So health education, how to prevent, how not to give to the family members. So I was also acting as a primary care doctor in times of prevention of COVID. Then an increase in my own stress level. I was worried that, okay, because of the passion, you end up seeing those clients and maybe you're catching the virus and giving it to the family members. So sometimes I was in a dilemma too, but I used the available protective equipments and took care of my clients. Now, I think that's all the challenges as a team, psychiatric professionals we faced. And we kind of managed well. Our numbers are coming down. So the stress is kind of relieved, not completely, but it's much better. So I needed to remind you that, we are all in mental health field or in the healthcare field because we have a passion for it. We want to help people. We want them to be better. So we can do it. This is a challenge nobody else or anybody else have experienced in the past. If we ask that question, no, we have never experienced this. So this is new to us. But remember, if there is a big challenge, there is also a lot of solutions for it. So you all are strong. That's why you chose the healthcare field. You are strong. Together, we are stronger and we are resilient. We are passionate. Together, we will thrive and help our community to have better mental and physical health. So that's all from my side today. And I use some references. The last two references, the CDC and some HSA, that's the Center for Disease Control, and also the Substance Abuse and Mental Health Administration. You can just Google it up and they have a lot of helpful tips, what to do during COVID and specific COVID issues and, techniques to overcome that challenges. So I hope so that's all from me today. Thank you so much.
Thank you, ma'am. Thank you for your wonderful session.
Okay, if you have anybody has any questions.
So there is one question asked by Mr. Sunny. So what are the mental impact of COVID on mental patients? He has asked, what are the mental impact of COVID on mental patients?
They have increased anxiety. That was the major reflection I have seen on my clients. Their anxiety level, usually many of my clients, I have been seeing them for last 3 years. So they were stable patients. All of a sudden their anxiety went to a high point, like they were having panic attacks. So the same medications what I have been using for them is not working anymore. So we have to add some more therapy, counseling. So increased anxiety was the first I experienced increased symptoms during this time. Then the second one was more depression was there, but more than that, sleep disturbance, not able to sleep. They were wired up to a point that they cannot sleep. So sleep disturbances caused a lot of more depression. And also there was some mood changes, some increased psychosis also experienced by clients, but anxiety was the number one thing on the list in the mental health. It was more through the general mental health clients, the increased anxiety. The severely mentally ill clients, majority of them were kind of never mind attitude. That surprised us actually.
Okay, that's the only question we had from the participants. Once again, I extend my sincere gratitude to you, ma'am, for taking your time from your busy schedule and sharing your experiences with us. Thank you once again.
Thank you.
So let us begin with our third session. Before beginning the session, I would like to remind you once again that feedback form link will be given in the chat box towards the end of the session, and fill in all the details carefully without mistake. The position of informal caregivers is one of the key issues in dementia care. The impact of COVID-19 on dementia patients' families, partners, and neighbors in their network is considerable. We have Mrs. Ashley Jacob to speak on challenges and risks for caregivers of ADRD patients. Mrs. Ashley Jacob, after completing her master's in nursing, has joined Alzheimer'S and Related Disorders Society of India, ARDSI, and works as a training coordinator at their National Training Center for Dementia Care Skills Training, Trivandrum. So I welcome Dr. Ashley to the session. Over to you, ma'am. Madam, you are not audible. Please unmute.
Okay, sorry.
Thank you,
Now
ma'am.
it's okay? Okay. Again, good morning to all, and thank you for the wonderful introduction which was given by the coordinators of this webinar. And this actually I'm so happy to say that to speak about the topic which was given to me, that is challenges and risks for the informal caregivers of ADRD patients. Okay, especially in COVID-19 pandemic, because in one or another way, anyway, we are usually, as a professional carers, we usually hear, see, or experience the problems or worries which may be experienced by the family members of Alzheimer's patients. So it will be very challenging situation for the caregivers. So very difficult to tackle the situation also. So I'll start to share the screen. Is it okay?
Yes, ma'am.
Okay. So before going to our main topic, that is challenges and risks, just I want to tell about the common symptoms or problems of Alzheimer's patients. That is, usually you may be knowing, but also I want to give a clear idea about the problems. Then if you have a clear idea about the problems or signs of Alzheimer's patients only, you will be able to know that how to tackle the situation. So as we all know, we have that memory loss is a common problem, and difficulty in performing the familiar tasks that they were performing easier, that when they got dementia, they find very difficulty to perform the same task. And also they may be having severe confusions, disorientation, and they may misplace the things, and language problems or communication problems will be the communication problem, in the sense they'll be having speech problems. Speech may be cut off in between, and they'll not be able to find the right word and to fill the sentences. And these are the problems. And also, other than that, poor judgment, mood swings or severely mood changes will be the, and our common psychological symptoms like hallucination, delusion. These are the symptoms, and changes in personality. So these are the common problems that may be suffered from any type of dementia patients. Okay, so next we'll be going to the challenges and risks of the informal caregivers. That is topic for me. Actually, the informal caregivers is nothing but just family members as of the person with dementia that we are considering as informal caregivers. Okay, so let us see that what are the challenges or what are the risks that they are facing in this COVID-19 situation. So why these challenges are considered so important? Why? What is the reason? Because being a caregiver for a person with dementia is very risky or very hard job or very challenging situation, because especially when dealing with the BPSD in the sense behavioral and psychological symptoms of dementia. These are the common problems which may be suffered from the person with the dementia when the family members are struggling to manage the BPSD of the person. So that time they will be feeling just challenging job. And also some doctors think that caregivers are hidden patients, because especially as a family caregivers as hidden patients, that means they'll be in a depression or they'll be in any other risk or stress or etc. So because of overburden of the work that they are doing, so they are the hidden patients. And also the experts would say that meaning of treating or caring the person with the dementia is like solving a challenging puzzle or solving a difficult puzzle. So that is very difficult problem or very difficult to manage, and most of the time the family members will be suffering how to manage the BPSD in a severe or in a tricky way. So most of the problems of the person with dementia we have to take in a tricky way. We have to have some knacks to manage the situation. So because of that only the caregiving, we can call it as the caregiving is very challenging. Okay. And what are the common challenges? First we look on to the challenges, and then after that the risk we will see. So first challenge is for the caregivers is role change or role reversal. By the name itself, we can say that in all the every member of the family or every member of the society is having their own roles in our family, in our society. So if the person is affected with the dementia and their family member as a caregiver, the role is changing. So that is the one important challenge that the informal caregiver is experiencing. Otherwise, we can call it as role reversal. Reversal of roles is not taken place. That means, for example, I will explain one example. So in a family of husband and wife, so if imagine the husband got dementia, Alzheimer's dementia. So earlier the wife was a housewife. She was a housewife. She will not be having any job, or perfectly she is stick on to the home or household duties. She will be not able to perform the outside task, because earlier her husband was doing or managing everything. But when he got dementia, her wife has to take the role of the husband. That is the role reversal. That is a very challenging situation for the informal caregiver when we concern with the person, when we talk about person with dementia. Okay, so that is the role reversal. And she will be able to tackle with the, even though she has to take care of the person with dementia, and also she has to take care of the household duties. Other than that, she has to look at the family and go for shopping and do everything on the outside or outside task also she has to perform. That is all earlier her husband was doing. So that now she has to perform everything. So that is a role reversal. She has to take the role of not only the wife, and she has to take the role of her husband also, what the role he was played before the onset of dementia. That is a role change or a role reversal. And the next one is change in relationship. That is also an important challenge for the family caregiver. So what is the relationship change? Here the same example we can say that if the husband is affected with the dementia, the wife is looking after the person as like a caregiver, rather than looking after an equal life partner. She assumes herself as a caregiver's role. So the relationship in the family, like husband and wife, will be changing. So that is called a change in relationship. So exactly we can say these two things by the name same meaning, the role change or role reversal and change in relationship. These are the two important challenges that the informal caregivers of ADRD patients are suffering. The next, what are the challenges we can see? Next one is common thing we be knowing that financial strain. Financial strain is mainly because of most of the family members as complained as the professional caregivers that they are having they are losing the career, they are losing, sometimes they lose the occupation, job, or they will not be able to perform very well in the job or occupation, and their supervisors are always calling, or because they'll be because of the complete absentees from during the work, and these are all the things because of that. And other than that, they'll be losing the promotions, especially in a higher job and all, and and sometimes the loss of occupation, they may lose the job also due to the prolonged absentees and all. So this may lead to a financial strain for the family members, and not only the family caregivers, the entire family will be suffering from financial problems. That is because of their overburden or overwork, as they have to take care of the family, and as they have to do the role of the family member, and also they have to take care of the person with the dementia. And lack of self-care, that is also one challenging situation for the family caregiver, because the person will not be able to do their own needs. They will not consider themselves as family caregivers, because they'll be most of the time they'll be dealing with the person with the dementia, ADRD patients. So they may lack self-care, and the important thing. And then next is emotional and physical strain or stress. That is a common and important, very important challenge that the family caregivers is facing or experiencing. Okay, so physical strain, in the sense we can say that physical fatigue, because I already told you that they may be struggling with their household duties, they have to take care of their own children, and along with that they have to take care of the person with dementia, because the person will not be able to perform anything by themselves. So for her, for the person with dementia, the family caregiver's brain is working, or the family members' health is working for them. So they may be physically tired, they become physically very strained, fatigue, that is physical strain. And stress, next is emotional stress. Emotional stress or stress, what is meant by stress? In the sense, our body's response, stress is our body's response to any adverse reactions or adverse circumstances. When our body fails to do anything or fails to respond to the adverse situations, our body may experience stress. So that is emotional stress. This is one type of emotional strain or tension that the family caregiver is experiencing. Okay, so last challenge is burnout, because first and all, once the person is not able to do, or they'll be having financial strain, they'll not be able to perform the self-care, and they'll be suffering from the emotional and physical stress or strain, and at the last time they'll be going through the stage of burnout. That means simply they'll sit quiet, they'll feel that the work will not be fruitful for the person or fruitful for the family in there. And because of that, they are completely tired, and they'll not be able to look after the family, and so because of all the things, they'll just feel an apathetic mood, that they feel that they don't want to do. If they do also, it will not come as fruitful, so sometimes they may quit from the job. So that is burnout. So these are the important challenges that the person with the family caregivers are experiencing. Okay, so next we can go for the risk. What are the risks for the ADRD for the informal caregivers? And before going to the risk, we'll just see what are the signs of stress. We are already seeing that person will be feeling emotionally strained or emotionally stressed. That is an important challenge. So how can you say that whether you are in a stress or whether the family member is stressed situation? What are the indicators of stress? That the person itself comes and tell us to the professional carers that they are feeling very tired. They will get easily angry, and they lose the interest in the same activities that they were used to enjoy. Earlier they were enjoying some of the activities, but now they can't because they are in stress. And sometimes they may feeling very sad and apathetic. Apathetic means they will not be able to do. They feel that not to do or not to do anything, just a passive nature, not active. Always it brings a passivity in the person. So always the person may feeling tired and sleeping pattern will be disturbed and becoming active very easily angry. So these are the signs of stress. By looking at these signs, we can understand that the family members are in stress. Next, we can go for the risk for informal caregivers of ADRD patients. What are the common risks? Here, risk comes when it affects the health of the person, when it affects the health of the caregivers. That time we can call it as risk. That means these are the common health problems that they may be suffering. The first one is depression, anxiety. Depression is a common risk that the informal caregiver is experiencing, because sometimes they will be failing the managing situation. They'll not be able to manage certain behavioral symptoms of the person with dementia. So that time they'll be experiencing the stage of depression. Okay, and then next, anxiety, whether they feel that whether they can fulfill the duties, or whether in the future whether they may be having fear that they themselves have will develop stages or signs of dementia by caring or always being with the person with dementia. That type of anxiety the person may suffer. And also the irregular sleeping pattern, because most of the time Alzheimer's dementia patients will be during napping, they'll be napped during daytime, and nighttime they not lose the sleep, and they may having the wandering sensation. So because of that, and all caregivers will not be able to get proper sleep. So sleep deprivation, because of that lots of sleep problems may happen, may develop in the person. And weight loss, because the person will not be able to already the physical and mental strain, and also will not be able to have food at the proper time, and that and all. So these are the common risk or health problems that can affect the family caregivers of ADRD patients. And next, we'll go to find out what are the challenges of caregivers in COVID-19 pandemic. In relation to the COVID-19 pandemic, what are the risks or challenges that the family members are experiencing? As we already know that the seniors are more vulnerable to get any type of infection, especially the COVID-19. As our government rule is strictly, the government is saying that above 60 age people will not be supposed to go outside, especially in this COVID-19 period. And even if the along with that, if they have dementia, especially they'll be having more chance for getting other type of infections. So, and what are the challenges for caregivers in this COVID-19? So we can surely see that we can say that the mask, we have to wear the mask while doing or while dealing with the person, because especially in this COVID-19 period. And if the caregiver or family member is wearing the mask, means the person will not be able to find out what is exact facial expression. But they'll not be able to identify the emotional clue that the person is giving, whether we are smiling or whether we are angry, whether we are sad. These facial expressions will not be able to identify by the ADRD patients. So that will be a challenging situation. So, and we can say that we already know that especially the intermediate person with the dementia, if the person is in intermediate or late stage of dementia, they will be more interested in our facial expressions or non-verbal language, because if we talk anything, or they will not be able to listen our verbal language, or they will not be able to understand what we are talking, because of the language problem. So most of the time they'll be having a look on the facial expressions. So if we are happy, if we are giving a smile, they'll be happy. So that is a thing, especially in the intermediate and late stage of dementia. So if the caregivers wearing mask, means it will be challenging for them. They will not be able to identify what is the facial expression, or how to behave, or how to respond. Sometimes there will be an anxiety. And also the person with the dementia or Alzheimer's dementia patients, always they want physical contact, especially in the middle stage or late stage. They want a physical contact, or they want the gentle touch from the family caregivers or from the caregivers. So especially in this COVID-19 as a role is because when we consider the social distancing, it will be also a challenging situation for the caregivers. Okay, so these especially these two are the main challenge that the family caregivers are experiencing in COVID-19 situation when they deal with a person with the dementia. Okay, so and also the caregivers, what are the other challenge the caregiver is experiencing? That means they will be in a conflict or they will be in a dilemma whether they want to consider the emotional needs of the person with the dementia, or they should be in a position to keep their loved one be safe without getting any infection. So these two things we have to take care of in our mind as a family caregiver, because a person with dementia or Alzheimer's patients always they want our support or they want our touch, physical presence, emotional contact, everything. So we have caregivers have to take in mind that is also they have to keep in their mind, and also they have to make the person be free from getting any type of infection. And also regarding the visits, if the person with the dementia or Alzheimer's patient is in staying in a facility or staying in a healthcare or Alzheimer's care center, the caregiver visit has already prohibited during this COVID-19 pandemic as per the government rule. So sometimes they want to see the person or immediate family member, and also and other member, the family caregivers always sometimes they want to they want to spend some time with them, and they want to see them. So these and all sometimes will not be possible. So if the person is in home or care center, caregivers will be having a challenge that they will be restricted to go to the center and visit the person, because always the visits to the elderly center or elder care centers are completely restricted during this COVID-19 period. And what are the precautions for caregivers? As per the government rule, everything you have to follow that, even when they are home or when each time when they go out and when they come back to the home, be sure that hand hygiene and sanitization is everything has to be followed, and wearing the mask, and especially respect the rules of the government. And when we see that everything is for our safety, not only for ours and for the person with the dementia, for the entire community. So safety is one of the most important concern that the caregiver has to look after. So next topic is our coping. How to cope up with this burnout of physical, mental stress, everything. Now we already have seen about the challenges and risk for informal caregivers. Next we can go for how to cope up with the situation. So here in this triangle, they have given more importance to the stress. We have already seen that what is meant by stress. Stress is a challenging situation, challenge for the family caregiver. So it is an emotional tension when we experiencing an adverse situation or adverse circumstances. So it is the body's response to when we exposed to any unwanted or demanding situation. So if the caregiver is in stress, if they don't have any adequate coping mechanism, surely they will affect the health. Surely it will affect the health of the person, and it may have negative influence on the health status, and the person may become ill, or it may go for developing any health problems like depression, anxiety, or any other sleep problems, etc. So if the family caregiver is having an adequate coping mechanism, surely it will not be having an influence on health. Also, it may improve. It acts as an improving factor for the health, and so they can. So we have to say that an adequate coping mechanism should be there, even though if they are struggling with the challenges of this. So that is this triangle says, if the person is in a stress, that means family caregiver is in stress, surely they don't have any coping mechanism, it will be having a negative influence on their health, most of the time they may be land up health problems. So, but even though if they are experiencing stress, if they have an adequate coping mechanism, very strong emotional coping mechanism, surely they will overcome through that and their health will be not affected. So that is the coping mechanism. So what is the main thing we have to focus on this? First, an important coping mechanism for a caregiver, we have to say that ask for help. This is very, very important. Ask for help in the sense, in the picture they have shown that only one person is pulling the rope and they feeling the very tired. But instead of doing by alone, if we do as a teamwork, in the second picture they have shown. So if you're doing with a teamwork, if you're maintaining a teamwork, means it will be very easy to tackle with the situation and they will be in a position to deal with every behavioral and psychological symptoms of dementia. So we have to have a teamwork, and so that for that we have to ask for help. So that is the importance of teamwork. And in that, what are the things we can importantly we have to notice that our organization Adrb, Alzheimer's and Related Disorders Society of India, so is having daycare centers and full-time care centers for taking care of the person with any type of dementia, especially Alzheimer's disease. So the family caregivers can ask help from outside, and they can take a break from caregiving, and they can make the person to admit in the center, and just they can take a break or they can have a break. So that is, and we have a respite care centers also, just for a break. They can look after by themselves. And we have a national helpline numbers, and in the helpline numbers, when always our experts will be handling the calls most of the time throughout the nation, national wide. The most of the persons will be handling or sharing the worries and anxieties or problems. Sometimes they may feel very difficulty to tackle with the situation or to manage the behavioral change of the person with the dementia. So usually they can call through the helpline numbers and ask suggestions from the experts or counselors or social workers. And the next is in the help caregiver support groups, that is support groups. Just Adrb is maintaining a support group, that is caregiver support group. In that, the family caregivers can have a discussion in this platform. We have a WhatsApp group, okay, caregiver support group. In that, they can share the worries, anxieties, everything, and problems. And the other family members or other family caregivers also, they can share the problems, and they can have a mutual understanding. And or if they get, sometimes they may get some support, or they may become calm or very happy, and very happy because when they experiencing the problem, when they see that others also experiencing the same problem, and what is the important measures that they have to take, this and we can discuss in the caregiver support groups, and that they can adopt in the family to manage with the person with the dementia. So that is one thing, is that ask for help. And then the next one is take care of yourself. Take care of yourself in the sense, the person, family caregivers, that means the informal caregivers has to take care of their own health. Otherwise, they'll not be able to deal, or they'll feel, surely they'll be in a stress. So they have to see the mind and body very healthy, keep the mind and body very healthy, and they have to look for the ways of relaxing, mind relaxing ways. They can practice exercises, yoga, meditation, and all. And also they can spend time with the kids or small children, playing with the children, or listening to music. These are the ways they can go for, just for relaxing the mind. Or whether they themselves can look for the ways to relax the mind. So simple exercises or meditation that they can practice and they can take care of their own health. And also, if they feel, if again the person is not able to overcome the stress, means they can get an appointment for the counseling session, and so the counselor will be helping to adapt to the situation, or they will be giving lots of choices for how to take after or how to look after the person with the dementia. Okay, so this is a second point. So how to cope up with the situation or challenges. And the next is set realistic and attainable goals. Most of the time, the family members will be making unrealistic goals. So they feel that everything, whatever the thing they are doing for the person with dementia, everything should be correct or everything should be perfect. Like that, they may be thinking, and they may be setting the unrealistic goals. So sometimes their caring is false. Sometimes the caring will not work out, or the person will not be able to manage the behavioral symptoms. That time they become frustrated. So if they didn't achieve the goal, surely they'll become frustrated. So what they have to do, they have to set realistic goals. Our main aim is that the basic needs of the person should be fulfilled. We are not saying that everything should be perfect, everything should be go in a right way. It is not like that. As we are human beings, everywhere always we make mistakes, and by the mistakes, from the mistakes we will learn. So how to manage? So we have to mainly focus on the basic needs that to be fulfilled. What are the basic needs? When considering with Alzheimer's dementia patients, the person should be, we have to see that either the person should be comfortable, clean, well fed, and they are in a safe situation, or they are in a safe environment. That's all. Only that thing we have to look after. They have to be well fed and clean and comfortable and safe in the environment. So that's all. Only if they are able to do, that is okay. So they can set the realistic goals and they can achieve the goals. So, and also the next point, that all the caregivers must keep in mind that give yourself credit, not guilt. That means sometimes the caregiving may not be work out. They have to have a lots of plans in their hand. Plan A, plan B, plan C, like that. So once if the plan A is not work out, they have to take another plan. So every plans will not be work out for every patient. So they have to look after their own health, and they can ask for help from the support groups and also from the art side. Okay, so give yourself credit, not guilt. So these are the coping mechanism that they can follow when they're dealing with a person, or when they are managing with the person with the dementia. So that's all about our today's session. So our main topic was informal. That means the challenges and risks for informal caregivers. Those who are informal caregivers of ADRD patients. And we have seen the challenges, risks, and especially in COVID-19 pandemic, what are the challenges? And also how to cope up with the situation. Okay. So thank you.
Okay.
Again.
Thank you, ma'am, for your excellent presentation. So we have few questions from our participants. So
Yes,
Mrs. Princey asked, how did you manage the care of people who were attending the daycare centers during this, previously they were attending the daycare centers during this COVID pandemic?
So during COVID-19 pandemic, how our center is managing? That is a problem.
Managing, yes, that is a question.
Okay. So, especially we are in our center, what we are doing in the sense full-time, we have full-time care centers that we cannot close. Still it is working. So what we are doing is, only thing is that we are restricting the visitors or even though the family members. And what is earlier what we are doing, the same thing in this time also we are performing, because in the mask making the person to wear mask is very challenging situation, very challenging. We will not be able to perform. So once if any other visitors is coming, means we have to maintain the social distancing, and we are not allowing to mingle with the person. And especially the staffs, those who are performing or those who are working in the center, they will not go out. Surely they will stay in the center, and they are not supposed to go outside for anything. So other outside works or any other cooking items and all, we got help from outside helpers. So the staff, those who are dealing with the person with dementia, will be totally they'll be dealing, they'll be full time, they'll be in the center only. So there'll not be any chance of getting any other infections and all. So that time, like that we can manage. And especially the visitors is strictly prohibited. With family, immediate family members, we can allow, that is also with a perfect prior permission they have to take out, and if it is felt that very needy only, we'll allow. Other than that, surely the same thing what we can follow, the same protocol. Okay.
So there is one more question from Ms. Alina. So what are the common problems that you have encountered by the caregivers during COVID-19 pandemic?
Caregivers. They actually during this COVID-19, most of the time the family members, they will be always, some of the persons will be staying in the home or staying in the home itself. So during that time, the members, that means the family members, always they'll not be, if they, even though they be going out, they have to take care of us, our rules, what is that, they'll be doing hand hygiene and everything, and after that only they'll be touching or keeping very emotional physical contact with the person. So there is no any chance of getting infection or any other problems that means occurrence of any other problems. So for caregivers, what is the problem in the sense? Only the emotional or challenging situation only they are facing. That means due to, I already told you that the emotional or physical contact. As when they go out, and when they come, after they go out, if they comes to the home, means they have to be strictly see that whether they are clean or not. Then only they are approaching the person with the dementia. So they'll be not be having any other risk of infection. And from the family caregivers, there is no any other challenges. That means wearing the mask or we are getting the social distancing. That is only a most of the time the challenging situation that they are facing. Because other than that, this they have to, the person and the family caregivers, the both they want physical contact. That means emotional contact. Then only the work, or then only the effort will be that caring will be effective, that the person will be more approachable to us. So other than that, there is no any other common risk or challenging situation. Okay.
One more question. So do you have any training program for the caregivers? So this question from Ms. Bindu.
Yes, surely. There is a program as like we are dealing with a training center, National Training Center for Dementia Care, especially in Trivandrum. In that we are doing lots of training programs. One is for professional caregivers and one is for family caregivers. So both we are doing, and one is as per the guidelines of ADI, Alzheimer's Disease International. We are conducting a program that is called DCS course, Dementia Care Skills Training. So that is for two categories, one for professional caregivers and other one for this one for family caregivers. So that modules will be different slightly. So and hours of hours also will be different. So if we are going for, if you're doing for professional caregivers, especially usually it will be certificate course, certificate program. And other than that, for the family, we are not issuing any certificate, just for informing certain or how to tackle or how to deal with the certain BPSD and all will be especially dealing with the practical aspects for the family caregivers.
Okay, so there is one more question from Mrs. Priya EA. Can you suggest remedial measures for patients with the word abuse in home situation?
Word abuse. Word abuse.
Yes,
no. That means verbal abuse.
Verbal abuse, she mean, I think. Yes, maybe verbal abuse.
Verbal abuse. That how can we can tell them that the ways of communication. Communication is very, very important with the person with dementia. So they will be surely experiencing, surely observing our facial expression. Surely, if we shout, if we shout or if we suddenly talk anything, that is sometimes that is also will be making a negative influence on the person with dementia. So word abuse in the sense, not only word abuse, other than we are not supposed to shout also. That is, we have to deal with the person with a very calm and quiet manner, or in a very simple sentences we have to use, and by the facial expression itself, they have to feel that they are comfortable, or they have to put trust in ourselves. And so that is a very important thing we have to do. Words sometimes, most of the time, the person will not be able to understand what we are telling. That is one thing. So and by rather than the talk or oral words they are listening, our facial expression or our tone of voice they are listening. That means if we shout, or if we our tone of voice is very high pitched, or in a very complex words if we are using, means that will be surely getting a negative influence on the person with the dementia. So in that time we have to be very simple, very quiet, and approach always from the front side of the person, and with a smiling face, very slowly, calm and quiet manner, we have to approach the person. And most of the time we have to think that we have to ensure that our presence, they should recognize our presence. They are not supposed to go in a rushed manner and go approach the person. It is not like that. They have to first give time, just they have to prepare the welcome, or prepare the approach of ourselves. So word abuse is very difficult, so we are not supposed to use any harsh words. So especially when dealing with a person with the dementia, they are feeling very well. They're emotionally, they becomes problematic. So we are not supposed to use such type of words. Surely, always we have to be in a calm and quiet approach, and simple words, especially in a smiling way, smiling manner, with a smiling face you have to approach.
So there is another query from Dr. Usha Marath. So whether the problems of caregivers increased or decreased with additional members at the home during COVID?
That is, during COVID-19, especially if family members is increased, that means surely it will be having a negative influence, because most of the time the person with the dementia, especially the Alzheimer's dementia patients, will be attention seeking. So always they want a carer to be with them, or especially in our center itself, we have a lots of patients in the center, and that time also we'll be giving most of the time one-to-one care. That means they have to have a feeling that they are listening. Some others are listening to them, or others are watching them. So like that, like children, they are also attention seeking. So always, if lots of family members are there, means sometimes they will not be able to have time to properly look after the person, or keep time or spend time with the person. That is negatively it will influence, because they want us to be with them. Sometimes, most of the time, the person with the dementia is having a clinging nature. That means childish behavior. Always they may be having one caregiver should be with them, and they may be shadowing with them, always went to the bathroom also. So like that, attention seeking they have as like children. So if the members are increasing, the person will not be able to provide proper care or proper attention to the person with the dementia. So surely it may be having an influence. So if the family members are increasing also, we have to see that, check that the person needs is met and person's emotional needs is met. That is surely we have to check or take into consideration.
Okay, so there is another query from Mrs. Bindu. So what is the solution for increased wandering behavior seen in patients?
Wandering. So wandering is a common problem that may be suffering, especially this sundowning syndrome. Sundowning in the sense, especially they may feel this restless behaviors in the late afternoon. During the late afternoon or nearly in the evening time, they feel restless, very restless and irritable. And that time only they'll be having this type of wandering tendency. So what we can do is that if the person is at the center, most of the time they may be saying that they want to go out, Sometimes we may be locking the door because they may be having the tendency to go out and all. So that time we can say, we can make them to enjoy some of the activities. We can make them engage in very interesting activities, what they are already performing or what they are interested. Suppose they are interested in singing, or they are listening, if they're interested in listening music, interesting old music we can play for them, and that soothing, that may soothe the mind, so that we can do. Other than that, we can have just for group play, group activities or group play activities like debates or very interesting group enjoyable activities that we can make out and do plan for the person. And if the person is engaged in any of the things, sometimes that thing, that means wandering tendency, will be removed from the person. And other than that, what we can do is that if the person is, what is the reason for wandering, that we have to understand. Especially why sometimes they maybe want to toilet, or want food, or any other basic needs, or they may be having pain, or because of any other reason. What is the reason, we have to find out. And if they are having if they are having feeling hungry or any other need, in that need we have to fulfill. Other than that, simply wandering means we have to make them fully engage or divert the mind of the person from the wandering tendency. So, and especially most of the time, the person music therapy will be effective. And other than that, reminiscence therapy is also sometimes will be effective. That means we can make the pictures, we can give a book or scrapbook, which are their life story book, that includes a lots of pictures, they're old photographs, that when they see the pictures, they'll be having the mind relaxed. So irritability and restless will be gone. Okay.
So there is another question, ma'am. How do we manage aggressive behavior in dementia patients?
Very good. Common behavior problem that is happening in a person with dementia. So always, this time also, what we have to see, that this is also a behavioral symptom. So what we can do is that in this time also we have to see that sometimes the person may be having any other reason or any other need to be met or need to be fulfilled. Because of that need only, the person may be behaving in such a way, aggressive behavior. So sometimes if they are in a pain, if they don't know how to express whether they are in pain or, so that time they may become angry, aggressive or violent, that and all. So that I identify the need. Other than that, we have to make them engage in such type of very simple. Earlier, as we told, that we engage in interesting activities, or sometimes they may be, and most of the time they may be having some particular skill. We have to identify that hidden skill in the person, and based on that particular skill, we have to design the activity for the particular person. So especially this reminiscence therapy, it will work out so to deviate the mind from the abnormal or this aggressive behavior to the normal thing. And other than that, what we can do is that just for a talk, just for a be with the person, and what is their interest or what is their likes. Based on their likes, we can talk about something, and we can talk the very interesting matter to the person, and that like that we can divert or deviate the mind from the person. And other than that, we can say that before going to the aggressive behavior or violent behavior, harming behavior, the person will be showing some signs that we have to identify what signs. Sometimes the person may bite the tongue or make a fist. So by seeing that, we can understand, the caregiver can understand that the next time they will be going to, next minute they'll be going to slap or any other behavior. Aggressive person will become aggressive. So before by identifying the symptom, that sign itself, we have to divert the mind, or we have to make the person to go take the person to outside or just to the courtyard and make the fresh air experiencing or influencing the fresh air, and see the garden, make the person to see the garden or nice flowers or colors or interesting things. And while these all the activities, we can deviate slowly, we have to deviate the topic, and like that we can make the person to change the that means divert the mind from the aggressive behavior. So all this BPSD, we have to go for mainly the person's likes and dislikes. We have to understand. Anytime, sometimes most of the person will be having certain likes, So based on that, we have to plan any interesting activities. Okay, like that we can manage these things. And also, even though, don't resist the person. If the person is aggressive or if the person is coming to slap us, so don't resist or against, don't argue or don't resist or don't behave in a negative manner. Instead of that, what we can do is that in positive manner, we have to be, if the person is coming in an attacking mind, we have to give a smiling face. So automatically, if we sing a very important or very which song they like, the particular song, if you are singing it, surely they will come to our mind, come to the mood. So like that we can change or tackle the behaviors.
Madam, some of the few participants are interested to know how this reminiscence therapy is given to the patients.
Okay. This reminiscence, actually this reminiscing is nothing but it is in the old memories. What is the person's old memories that we are reminiscing or making the person to remember by looking at the pictures or by looking at the photographs or anything. So these two things are different, remembering and reminiscing. Remembering in the sense we are directly, we may ask the person. Sometimes some persons may be asking, what is your native, what is your born place, or where are you brought up. So like that, if you're directly asking a question, means we are making them to remember. It is remembering, but it will not work out for a person with a dementia, especially in the middle stage, and or they will be having lots of short-term memory loss will be there, and they'll be having only a long-term memory, that is in long years back they will be. So that memory, if they want to boost out, means what we have to do means we can make a blank book, we can give a blank book and ask the person itself to stick some of the pictures or some of the important caregivers or family members, those who want to be with those who like and immediate family members pictures, or other than that, sometimes they may be very interesting in their enjoyable activities like hobbies and all they were used to enjoy. That sometimes they may be they might have got any prizes or any achievements in that period, so that and gifts, they may be accepting the gift from the ministers or anything like that, pictures that shown some of achievements, that type of achievement photos or anything, if they have, means that we can put on or stick on to the blank book. And again, their interesting activities or interesting phases and interesting days, what they again want to recall, especially the wedding day, especially the birth of the first child, or their birthday celebrations. So that and all special days or enjoyable days, that celebrations photographs is there, means that we can stick on the particular place on the book. And when the person is looking after or closing the page and having a look on the pictures, surely the memory will be going back, and they will be like that, they will be reminiscing. For example, I can say that if you want to know the birthplace, but if we can show their house name, the picture of their house, if you are showing in a book, means surely they will realize, they will think, they will see the picture, and the memory will be flagging in the brain, and they will be starting to think of the birthplace. And surely, without asking, they may start to tell that this is my house, this is the place where my mommy is feeding me, this is the place where I was playing or I was wandering. Like that, they will be starting to talk. They'll be very interesting to talk. So that is reminiscing. That means we are showing, or we are giving a clue. We are not directly asking anything openly. Okay, so rather than asking, we want to talk the person. We want to make the person to talk regarding the memories. So the most of the time, the person will be very interesting to live in their past memories. they will be very happy in the past memories. So for that only we are doing this reminiscence. So by seeing the pictures, whether the person itself realizing and they started to talk. So that is the reminiscing. Okay.
So there is another question, like what should caregivers look for regarding changing behaviors of someone with dementia?
Changing this, in always we have to, I already told you that this changing behavioral change is having lots of triggers. First, we have to identify what is the trigger, what is the exact cause for the improper behavior. If the person is doing any behavioral change, means we have to identify that whether the person is having any need to be fulfilled. It is not because of dementia, or it is not because of Alzheimer's disease. We have to identify the triggers. That means we'll be having lots of triggers. That means communication problem. That means the person itself, they may be having communication problem, because they'll be having speech problem. They'll not know, they don't know what to communicate, when to communicate, what is the right word which has to be placed in the sentences. So meaningless sentences they'll be telling. So and if you are telling something also, they'll not be able to understand. So our communication, our way of communication is not good with the person. That may affect their behavior. That may provoke the person to behave in proper manner. And other than that, our activity, what activity we are giving to the person. That means, I told you that meaningful activity should be given to the person. Meaningful and purposeful activity. Because we have to improve the cognitive level, and we have to improve the life, we have to make the person happy. And so for this and all, what type of activity or what type of task we are assigning to the person, that is also will be having a negative influence sometimes for the behavior change. That means if you are giving an activity, whether it is overstimulating or whether it is understimulating, that means it is beyond the level of the particular skill of the person, or beyond the skill of beyond the ability of the person, that may surely negatively influence the behavior. And other than that, if the person is having unwell needs or unmet needs, like if the person is not comfortable, if dress is soiled, or sometimes person may be having urinary incontinence, or maybe spitting, or maybe drawing saliva. So always the dress may be soiled, or we have to see that whether the person is comfortable or not, and whether the person may be thirsty, hungry, or whether they may be having pain or feverish or any other infections. Or because if they are having these all the needs, surely they will behave improper. So, and other than that, stress or environment will be also having a negative influence. That means where they are. Suppose most of the time in the center or in the unfamiliar environment will be having a negative influence, surely. Because always, that's why we are telling that a person with dementia should be kept in a very well-known environment. We are not supposed to bring any unfamiliar person to, or we are not supposed to introduce any unfamiliar person to the person with dementia, because the person equilibrium may change. Already they are in a confused state. So here again, if you are introducing any unfamiliar situation or unfamiliar environment, and suppose if the noise level is not audible, sometimes if the noise is distracting them, that and all may affect the negative behavior or they influence the behavior. So we don't consider, we ask caregivers, we are not supposed to consider that it is because of dementia the person is behaving such a way. It is not like that. Because of dementia, the person is behaving only 5 to 10%. Most of the time, most of the percentage, because the person is behaving improper way, because of it is maybe because of our communication problem. Otherwise, what activity we are giving, it is not sufficient for the person or not according to the taste of the person, or if the person is having pain or any other need. So that is the thing we have to check.
Thank you, ma'am. We have no further queries. So once again, I extend my sincere gratitude to Mrs. Ashley Jacob for this informative session on informal caregivers' pain and stress during this pandemic to care their loved ones with dementia. It is indeed our pleasure to have you with us.
Thank you.
Thank you, ma'am, once again.
Thank you for the organizing committee and thank you for all the participants. Thank you once again. If you have any queries, again, you can have a mail ID of myself. So, shall I share, ma'am?
Yes, ma'am. You can share.
Okay, one second. This is a mail ID of myself. So official ID, you can offer all the participants and all the members also attended. Again, if you want to know further more against or regarding ArtSci and its services or anything, you can talk or you can inquire. And especially for the nursing, Lisie College of Nursing, especially I'm thankful to organizing committee for inviting me to this seminar or webinar. Okay, thank you, madam. Thank you, madam.
Thank you, ma'am, once again. So with this, we have come to the end of today's session. Now I take this opportunity to thank the eminent speakers for the day. Mrs. Ajla Gaikwad, she has discussed the challenges and risks for ADRD patients in detail. Thank you, ma'am. And Dr. Bindu K. Jose has well explained the challenges of mental health professional and enriched us with her experiences in their setting in US. And Mrs. Ashley gave us an account on challenges faced by the informal caregivers of dementia patients and your explanations to the practical problems which these caregivers face. It was very useful to us, ma'am. Now I invite Mrs. Divya to give vote of thanks.
Good afternoon, everybody. First day of our webinar series is concluding now. First of all, I extend my most sincere thanks to the Lord Almighty. On behalf of myself, I extend a very hearty vote of thanks to our Honorable Director, Father Paul Karedan, Assistant Directors, Father Jerry Nyaliat and Father Shainu Munyeli, our beloved Principal, Professor Dr. Usha Marath, who spared time from their busy schedule to grace this occasion. I take this opportunity to thank the eminent speakers of the day, Dr. Ajla Gaikwad, Dr. Bindu Jose, and Mrs. Ashley Jacob for being with us and enriching us with your knowledge. We are grateful to the time and effort you took to share your thoughts and experiences with us. Thank you all for being here today, taking your time patiently to listen to the presentations. Tomorrow the sessions will start at sharp 10 a.m. All are requested to join 5 minutes before the session using the same link provided. Have a nice day. Thank you all.